How's Australia going to tell us how we're going to solve that problem? It's called organisation.
Thank you very much, and thank you for the opportunity to present. Today I've been asked to talk about how do we work with an organisation to get some of the changes we need for our patient. And the examples I'll give are from the Australian context, but they can be applied to the majority of the organisations in which we all work. In Australia, of course, we have some unique wound management challenges before us, particularly our wildlife and our fauna, but overall, the sorts of wounds that we ask to manage are not much different to the sorts of wounds that you're asked to manage. I want to begin with just a small snapshot of the Australian healthcare system to give you an indication of the depth that we're dealing with and then the strategies we're taking to try to change that. I must preface the comments I'm making by the fact that we've had a new government in Australia and they handed down their first budget last night. And so some of the things I'm about to say, I think, are in the historical rather than the contemporary areas. We are a small population, 23 million, and in the space of this presentation, we'll actually make a net gain of 8.5 people by having 6.8 die, 6.8 born, 2.8 die, and we'll immigrate 4.5 people. So my condolences to those families who just lost a couple of people, but overall we're making a net gain. We're distributed over a very large area, okay? So whilst a lot of Central Australia doesn't get used a lot, our eastern and our western and our southern shores are where we tend to aggregate. What worries our government the most is though when you look at our age distribution and this quite clear bulge in the middle is what is going to move into the older aged care brackets, and it's no different for Europe and it's no different for North America. We have been actively populating after the war, and now that those people are actually starting to reach old age, and where they should have died off, they're not. So we're now starting to see that bulge move through the system. Our healthcare status, though, has some good and some bad points. On the positive side, we actually have a lot higher age expectation than we've ever had in the past. Our quality of life is seen as quite popular. 82% are quite delighted with our quality of life in Australia when we're surveyed. We have the lowest number of smoking per head of population in any OECD country. 1 in 7 people will be smoking after the age of 14. And most children are immunised by the time they're 1 year of age. So they're positive things and we're quite proud of. On the negative side, however, our Aboriginal or Indigenous populations have quite a 12-year shorter life expectancy. We have the highest rates of obesity of any OECD country. Our diabetes has doubled in the last decade, and our breastfeeding sits around 49% for 3 months, and we know that we should try to make that to 6 months. So we have some challenges ahead, and they're probably not different to those that you face within Europe. In terms of our burden of disease, the cancers and cardiovascular diseases are those that plague us the same as they plague your populations. But more importantly, it's as we get older, we start to see a combination of these diseases or aggregation. So by the time we're 65 plus, you can see the percentage of people who have 4 or more conditions has increased quite dramatically. And those who have 2 or 3 conditions have increased quite dramatically. So we see a large increase in the different number of pathologies within the older patient, as you do, I'm sure. Access to our healthcare system is via our general practice doctors or our nurse practitioners. So the primary healthcare is how people tend to access the system. And then there's a range of non-primary healthcare services that people can use either as a private or a public citizen. And then on top of that, we have specialised services of which you have to be referred through via the primary healthcare system. But it's not equal across locations. So if you look at this distribution, you'll quite clearly see that things like specialised services and that get quite rare as we get into the more outer regional areas or the remote areas. However, things like primary care start to increase because that's the mainstay of healthcare system delivery in those environments. Our personnel, I suspect, are very similar to yours. We have 266,000 people actually employed in the industry. We have 560,000 people employed across both areas, both doctors and nurses, And then we have 236,000 people employed in the support services. So these are a lot of people that we're dedicating resources to. And if we look at the actual breakdown of the group in the middle, you'll see the majority of those are nurses and midwives, with a smaller number of medical practitioners, allied health, and then dental practitioners. So I suspect this is the same, and I have had a look, as the majority of European countries. The funding does differ, and it differs by location. So in a state, you have certain things funded. At a federal or national level, you have certain things funded. And then there is also a private and a public system. And this diagram depicts some of the funding sources. And again, you can see public hospitals, we see mainly a state government, where community health systems are mainly our national government fund them. Now, because of this complexity, we have to work out how does a patient navigate the system. Because as much as we talk about putting the patient first, our systems have been developed around the healthcare practitioner and the healthcare systems, not the patient needs. And so this diagram was drawn up just last year to try to look at how patients actually access or navigate through the system. Here it is, you can see this. It's quite simple, isn't it? Move through it quite easily. And more importantly, you'll see right down the bottom corner there, there's actually an option out of the system, and that's called dying, which is good for the patients, but unfortunately for the healthcare practitioners, we can't get out of it, and we live within this system all the time. So what have the outcomes been? Well, the outcomes pretty much have been things like delays, duplication of services, mixed messages to patients, and then a circular referral where you get the patient back to you after a while to say, you told me to go and see this person, they told me to go and see this person said I should come back and see you. And we see this consistently, where poor patients aren't having their needs met. This is an example of some of the patients we deal with, small problem. You can see it's quite a mixed type of environment for that person, for that particular animal. So the government's come up with a number of conclusions. They know that our system is no longer financially sustainable in the things that we're having to face in as our population gets older. So they've started to looking for solutions about how do they address this particular problem. Of course, one option is we just need to euthanise everybody at 65, right? It's not particularly popular, though, as a decision. So what our government have said, well, if we're not going to die, then at least we shouldn't have to pay you a pension until you're 70. So they've changed that from yesterday. But more importantly, they're starting to do a lot more work now, and has been over the last 5 to 6 years, to look at how do we get more efficient use of our healthcare resource? How do we get available information that tells us where we're using it and how we move it around? How do we get challenging to traditional professional boundaries so that people are willing to take on new and different tasks for the need of the healthcare system? How do we coordinate care to reduce duplication or delays? And more importantly, how do we empower the patient so they drive the system rather than the healthcare professional? And I want to just provide some Australian examples of how we've done each of those aspects. But what these things do is provide a lot of opportunities for wound care. And so the take-home message for today is if you want to have differences in wound care, work with the organisations in which you function and look at the ways in which you can contribute to the overall agenda and try to move the wound care agenda forward. So let's have a look at an Aussie example. In terms of improving information, we've reviewed a number of our national minimum data sets. So drug and alcohol, mental health and perinatal data is collected on every single episode. So we're now revising that and saying, is there better ways that we can have it, as we were talking about, collected in clouds and available in a much more timely fashion. But more importantly, we're setting up new data sets around things like Indigenous primary health care, public dentistry waiting times, prisoner health, which we have no data on at all, and radiation waiting times. Just examples of areas where we've identified the need to have established databases that we can get to. And as Juan said, these need to be secure and they need to be proper. I'm always interested when you go to the National Library of Medicine in Washington, where the CINAHL and the PubMed and the Medline clouds live. Okay, we talk about a cloud, but they're really a computer machine. And they're built into a hill. And I asked the chief librarian why that was. And he said back in the 60s when they built it, it was so if the nuclear holocaust happened, the actual database would be protected. And that's why it's in the hill. So protection's important. So after the Holocaust, you could walk up to the reference desk and say, What's the latest on radiation burns? Right. What this does is give us the opportunity to have wound-related databases, and we've already started establishing the venous leg ulcer registry in Australia. But we want to go much more on this and actually have people who treat any chronic wound contribute to a database. It's a big ask, we're busy people, but there's ways around that. The next thing is, how do you go about changing roles and coordinating services? Well, we've said primary health care is where the change needs to take place, and traditionally primary health care has been run by medical practitioners. 4 years ago, our government decided that they would change the primary health care organisational structure around something called Medicare Locals. As of tomorrow, they're going to be called primary health care networks after the last budget, but there are 61 of these Medicare Locals. And I don't expect you to read the whole slide, but the important things, the important aims of these groups are they're multidisciplinary, they integrate and coordinate services, they improve patient care, they locally focus and are responsive services, they have a performance of primary health care, and they're actually efficient and accountable to the government for the outcomes for that particular population. Now, these have been wonderful initiatives, but they have had a large amount of opposition from existing healthcare professionals as they've come into place. They've also started to change the funding for primary healthcare. So the slogan that the whole area goes under is called Living Longer, Living Better. So over the next 5 years, or next 3 years now, the government have put in 3.7 billion Australian dollars, and that's to look at how do we get better home healthcare packages. How do we get consumer direct care? Because that's what you have to demonstrate to get your hands on any of this $3.7 billion. You have to demonstrate that the care you give is directed by the consumer, not by yourself or other healthcare organisations. And that takes a real change of thinking. That takes sitting down, actually looking at, as we've heard, what does the patient want? They want something that makes them clean and doesn't stink. They don't want something that's going to last 4 years in terms of addressing. Now, this has provided wound care opportunities by actually starting to say, well, let's look at patient education and clinical education. Let's have the ability for a patient to self-care around wound care to a certain degree. A colleague of mine in Singapore has 3 layers of care. He builds buildings and they have 3 levels. The bottom level is a normal clinic, and you go in there and you see a doctor. The second level is a telephone call centre, and you can ring up this person and you can say, I've got a bit of a problem, can I get advice? The third level of his buildings are television studios. And he develops a number of audio-visual packages that are available on your phone, on the apps. So if you're and it's targeted to the maids in Singapore. These are often uneducated people who look after the most valuable resources, the children or the elderly clients. And they can push on this app and it says, my baby has diarrhoea, what do I do? And there's some advice. If they're still not happy, they can then ring up and say, I still want more advice, or the person on the phone might then say, why don't you come into the clinic because I think you need to be seen by a medical practitioner. So this is a way of actually triaging care so the patient can help themselves, and then as they're needing more professional care, they're directed in that area. A lot of the time they solve the problem with the app and the patient education. How do we go about empowering the patient? Well, this is the other important thing I've just been talking about. The patient needs to know about what's available and where to get it. And we've set up 3 distinct portals. One is My Hospital, where you have 1,000 public hospital and private hospitals data available for the general public to look at. We have My Healthy Community, which is an examination on compared local healthcare networks. And then we have My Aged Care web portal, where you can actually get help to navigate through the aged care system. This is what they look like. So here's My Hospital. You can see quite clearly a number of resources, and you can say, show me the hospital that has the highest incidence of hospital-acquired infections in my local area, because I don't want to go to that one, right? But what's the pressure area incidence like? What's the falls like? What's the skin tears like? So these are all available so that patients can interrogate the data themselves. Here is My Community. So it's got a lot of community educational material on it, but also what's available in their local area and who should they go to start accessing or exiting the healthcare system. And this is My Aged Care group, and this is really popular amongst people who are trying to find aged care services for their elderly parents. And they go there, they get the advice straight away, they know who to target, who to ring up, what the star rating of the aged care service is like. So these are very, very important initiatives set up to try to give the patient the power to interrogate the data and understand it. How do we build this around wound? Well, we need to make sure as these sorts of things are developed, these clouds of data that patients are going to have access to, that we have the wound-related information in there, so that our message is quite clear to people about how they get care for their wound, as well as other things that will be in those databases. The other area the government have taken a lot of time on is starting to look at e-health and saying, look, we can't deliver specialised services in person to these remote and rural areas. We need to rely on technology, as we've seen demonstrated here, to do that. So our Department of Health has a telehealth support program. This is some $13 million of money they've provided to actually fund some of these areas. And the website you'll see there, and I'm happy for people who want them later to look at that. Our government have also set up a clearinghouse, so any evidence on telehealth, research evidence, is put in this clearinghouse. So we can go there at any one stage and have a look and see what's being done, or has been done, to start to look at some of the answers. And then we have the Australian Telehealth Society, which again provide a number of different resources about how do you go about setting up a telehealth service. How is it remunerated? What technology do I use? What are the standards around provision and privacy of patient data? These are important resources to make it happen. Otherwise, you'll have lone rangers who are technophobes, who love technology, who will be just picking up and trying to do things themselves. And that will never work as a system. So in conclusion, healthcare organisations and governments will need to achieve efficiencies. We know that. And if we want wound to be part of that, we need to actively engage with our organisation. See what the goals are, see what our goals are, and see where the two come together, and actively lobby to have our interests included in any organisational change as we move into the grey tsunami that's being predicted. Thank you very much.